So I thank you, Barbara, actually for a nice introduction and make my next presentation easier. I think here's what I'm going to talk about today. So I'm actually switch gear. Even though I had a medical training, but I was doing research for the last 20 years until recently we moved to human. So here's the problem, right? The problem is our cognitive ability actually decline as function of age. Here's actually when you go from 25 to 80, all the cognitive ability like inductive reasoning, spatial orientation, and the numerical ability, and of course the learning memory, everything actually decline as age. So it's a surprise. When I look in this graph, even I'm getting surprised. The peak of our cognitive ability is about 25, and then eventually getting down. So around to, I think when we lost 60% of our cognitive ability, then you get into the trouble, like a dementia state. So that's here actually is another interesting test, and the results we got from converting one of the cognitive tests called trial-making test, B. In this case, we just converting the speed of the trial-making test, as time to finish the trial-making test into speed. Idea is that this is real data. So on average, the speed of processing cognitive ability actually decline about 1% per year. So essentially, in 40 years, we actually lost about 40% of cognitive ability. So actually, then you're going back to say, what is underlying scientific basis of such cognitive decline? So in this case, actually, if you look at the brain, what happened is obviously, if you look at the brain, this part of brain is the hippocampus and temporal lobe, which is important for memory function. The front part of the brain, which is the prefrontal cortex, actually is important for executive function. So when during the aging process, the brain in general have atrophy, but this atrophy of brain are not homogeneous. So if, for example, if you look at visual cortex, in visual cortex, there is not much atrophy during the aging. But the two critical parts of brain aging, one of them is prefrontal cortex, controlling executive function. Actually, their brain tissue, the brain size actually starts to shrink during the aging. And there's significant atrophy here. There's also significant atrophy in the hippocampus. So that is the neurological basis of the sort of lost the brain function. Now, so here's the little bit basic, I call basic neuroscience. And of course, everybody here know the brain is made of neuron, right? So neuron is elemental communication units for computation. So if you look at the neuron, and here's the cell body, and there's a dendrite tree, and each of the green spot is the location of place called synapse, where the communication occur. So obviously, a lot of people actually think about the brain aging is a lost neuron. That's why you need a stem cell and rejuvenation, regenerate neuron. In fact, that's a very late stage. The majority of the neuron, majority of space of neuron is occupied by dendrite, by synapse. So in fact, during the Alzheimer's disease, even after people die, if you look at the number of neurons, they only lost 9% of neuron. So what they lost most of the time is like a tree. When the tree, before the tree fall down, actually they lost a leaf. So in this case, there's a huge loss of synapse before the neuron die. So in fact, if you look at the clinical data, even though there's one of the dominant hypotheses, A-beta hypothesis, amyloid stuff, in fact, if you look at the best correlation between the cognition and the neurologic basis, the best correlation actually is synapse number. Here actually show the synapse, which is communication device of the brain. The synapse density decline with aging significantly. This is the number of synapse and during the aging. Also, if you look at the clinical side, in the MMSE, this is really the cognitive ability of the Alzheimer patients, their MME score is linearly correlated to the synapse density. That means when you lost synapse, actually then you lost cognitive ability. Even Alzheimer patients, the higher the synapse density, the higher their cognitive ability. So this actually brings to a simple question: how do we solve this problem from basic science point of view, right? So then this actually gets into the issue of how to prevent the synapse loss in brain. Where in this way, we're transfer a complex, a major neurologic disease into a more simpler scientific problem. That is the how one can actually prevent the synapse loss in the brain. So to study this question, actually, one needs to know molecular and cellular mechanism unregulated synapse density. So this gets into my contribution, my lab's contribution to this particular problem. So we actually are very beginning, even starting 20 years ago when I was a postdoc at Stanford, we are not interested in or not study disease directly per se, rather we are working on the neurologic mechanism of synapse. So what exactly controls the number of synapses? In this case, each of the green spot is location of synapse. So the question we asked 20 years ago is how the synapse number are regulated. So that is a sort of like my trajectory. Our research is totally different from other people, because other people starting from disease, we starting from normal brain, say how the synapse number is regulated. So here we actually use a very interesting advanced technology. Of course, eventually I'm going to get into the human. I'm talk about the basic science first, and eventually tell you how you go from basic science into the eventually go to human clinical trial and show there is something very promising. So in this case, actually, each of the green spot is the location of functional synapse. We develop a new dye which allow us to even quantify the location and the strength of individual synapse. So one of the first interesting observation we have, this actually we saw this 20 years ago, is a very interesting relationship between the synapse number and the synapse strength. Because each synapse in brain can actually communicate. The strength of communication is the what they call probability of transfer release. Because when action potential arrive, each of the spot is a location of individual synapse. So the height of this cone is actually the strength of synapse. So you can see actually in this place, both are the branch of dendrite. In the top branch, you see many, many small, weak synapse. And the bottom branch, you saw fewer, actually, but strong synapse. So here's a very interesting observation we have starting 20 years ago. That is the strength of synapse, like how strong they can release transmitter, how easy for them to release transmitter, versus number of synapse, there is inverse relationship. That is in the single branch. The stronger, if the synapse number is high, here's a number of synapse. When the synapse number is high, they are pretty weak. When the synapse number go down, actually they become stronger. Because then, why this is interesting? Because what this interesting is, remember, I told you before, the major problem of Alzheimer's disease is lost synapse. Okay, that's a major problem, right? But here you show, here we found when this, when synapse is big, when the synapse is strong, actually the number is low. So this gets into a very strange conclusion, that is to solve this problem, to bring the synapse number back, ironically, we have to figure out a way to make synapse weaker. So that is almost a counterintuitive. You want to make synapse weaker rather than make the synapse stronger. So nobody obviously have this idea in their mind about use this strategy to develop a drug for treating Alzheimer. So then we have done so many experiments, say, okay, how do we make synapse weaker? So this is really basic science. That is, the synapse are, in this case, for presynaptic terminal, it is their calcium sensitivity, because calcium triggers the transmitter. It's calcium sensitivity determine the strength of synapse. So essentially, we did many experiments showing many molecules. We show anything we do, if we can reduce calcium flux to the brain, to the synapse, we can make the synapse weaker, okay? So there's many drug candidates there. So it's tons of drug with screening. However, here we stumble upon something very simple but very interesting. That is we found that one of the simplest molecules in our brain, which critically control the synaptic strength, is actually magnesium. So magnesium actually is a mineral from our food. The magnesium actually controls the synaptic strength, That is, the higher the magnesium concentration, the lower the probability of transfer release. Then this gets into the most interesting results I'm presenting today. That is also here we show the number of synapse, okay, functional synapse on dendrite branch is actually linearly correlated to the magnesium concentration, intracellular magnesium concentration in brain. Now, in a further experiment, we show the magnesium is actually a controlling number of synapses. It's almost like a trophic factor, which directly controls the number of synapses in the functional the brain. Okay. Now, this actually gets into a very interesting issue backwards. That is even for me, I'm very confusing. If I remember the graph I showed you, during entire aging process, when we go from young guy to old guy, we only lost 40%, maximum we lost 60% of synapse, okay? 60% of synapse. Then, but our cognitive ability from smart guy to be, let's say, could not function, we lost the cognitive ability completely. Even though structurally we only lost 40% of us, but we lost cognitive ability. So why that happened? Because on the other hand, if you think of there are patients which only have half a brain. Let's say if I have a brain injury, I might have lost when I'm young. If I lost half a brain, I can still have a normal cognitive function. So why we lost 40% synapse? We actually lost the entire cognition. So here's actually a reason why. Because what happened is the single noise ratio in electronics, the ability to process information is significantly reduced, like by several fold when the synapse number is reduced. So that is really the reason. So here I'm going to get into the interesting part. That is if we found the change in magnesium is a molecule which controls the synapse density, can we use this strategy to enhance cognitive ability, right? Now you might say, aha, it's simple. It's a magnesium. There's a lot of magnesium supplement already in the food, and maybe we're just taking either more vegetable, and we were able to actually just probably prevent Alzheimer's disease. That was our early idea. Then we actually did a little more work. We found in our entire body contain about 24 grams of magnesium. And half of the magnesium are in the bone, and half of magnesium it's inside of cell, neuron. The problem is the brain magnesium have a much higher magnesium concentration in the blood. So there is an active transporting process transporting blood magnesium into the brain. And so from that angle, it's actually very difficult to increase the brain magnesium. So I follow the tradition of Silicon Valley. So we built a biotech company in the San Francisco Bay Area. So idea is, can we find a molecule which can selectively elevate the brain magnesium? So this is really it's a biotech company. So after tons of work spent, tons of animal, finally we actually found one molecule. This molecule is called CRNA. Now, CRNA is interesting. CRNA, later on, we did not know when, 10 years ago, we found the CRNA. Originally, the CRNA is a metabolite of vitamin C. Reason we show the CRNA actually is naturally present in our brain. The CRNA concentration in the brain is extremely high. It's about 0.4 millimolar. So by animal research at the very beginning, we show the magnesium cyanide is a new magnesium compound which can selectively elevate the brain magnesium. So in this case, first we have to do animal experiment. Like the traditional, you go from animal, then eventually go to human. So first what we show, if we actually use magnesium cyanide, new form magnesium, we can increase the brain magnesium. And here we show when we increase the brain magnesium in the rats, we can increase their synapse density. In this case, it's the prefrontal cortex area. We can increase synapse density by 30%. Another important part for learning memory, cellular mechanism learning memory, is the long-term potentiation. That's called synaptic potentiation. We also significantly increase the plasticity of the synapse in the prefrontal cortex. Remember, I also told you that another brain region which degenerates quickly and causes the memory deficit is hippocampus. So in this case, we can actually increase hippocampus synapse density by 80%. In this, for example, dental gyrus is critical for memory retrieval, and actually the synapse number is increased by 80%. And the synaptic plasticity also increase. So this compound in the animals experiment, we show we can actually increase when we feed in the animal, the memory accuracy can increase within about 2 or 3 weeks. Then stay there if we continue feeding the animal. If we remove the compound, unfortunately, memory doesn't stay there. The memory lost, but if we give a compound again, the memory come back. So this is short-term memory and also long-term memory. Then here we show there is actually a nice correlation between the number of synapses and the memory function. So there we show linear correlation between the number of synapses and linear function. So in this case, the open circle are the wild-type animal without treatment. The black spot is this group of animal after treatment. You can see the synapse density going up and the memory capacity going up. So the one thing actually I think that Barbara has shown quite interesting, when the people getting old, not everyone got Alzheimer. Of course, she showed 1 of 6, right, and in the 65, and 1 in 3rd in 85. The one interesting thing is in this cross from animal, rats, monkey, and human. That is if you look the cognitive ability of young people, everybody is very similar, like here. When you look in the old people, some of them are actually getting old, they're still pretty good. And some of them are getting pretty bad. So what happened in this is aging, and here's the old rats. In old rats, before the treatment, so everyone, some of them are good, some of them are terrible. So what happened with the treatment is treatment actually bring those terrible guys up, did not make the best guy better. So this is really what happened in the animal study. So here we are basically tell you we invent a new molecule from basic research. This allows us to selectively increase the brain magnesium, and because we demonstrate brain magnesium is critical for controlling memory function. And we actually can, when we're treating animal with this new compound, we can enhance working memory, short-term memory, and long-term memory. And the time course of memory improvement actually can occur quickly, from 18 to about 2 to 3 weeks. And the enhancement is repeatable and reversible. So then we actually, obviously, then after another few years preparation, then we start to say, can we use this to, finally we have to move into human. So human is more complicated because human is not just about improved memory. For example, FDA doesn't even care the memory. FDA asks the fundamental for drug improvement, like the CDR, is look the global cognitive ability. And also any drug development, the reason it's so difficult to prove any drug is because you have to show the patient's quality of life is improved. It's not just a memory task. You say, well, can they balance their check? Can they actually take care of themselves? So in this case, actually, we actually getting back to an interesting question, more like what they call intellectual capability. That is essentially IQ, right? So if you develop a drug to improve, restore the cognitive ability, you cannot just look in the memory. You have to look in everything. You have to look in the reasoning capability, spatial ability, and memory and processing speed. So this everything, when you combine all of them together, then you got a global cognitive ability. That is really the almost like equivalent to IQ. They call in the biophysics they call the G. So in this case, actually, our human trial design take advantage of our understanding at the synapse level, right? So suppose we can improve the function of prefrontal cortex and hippocampus. Then we look in the individual cognitive ability, like the attention capability, memory, reasoning, and spatial ability. Then this I call elemental functional capability, and eventually transfer to higher level of ability. That is the decision making, planning, reasoning, and flexibility. Finally, reach to the intelligence. So this actually, but of course, intelligence actually transfer to the daily function, right, for patients. So in this case, when we go to our first human trial, of course, we do the double-blind placebo-controlled trial, where we know from structure point of view, we actually can affect the prefrontal function. We can affect the temporal lobe function. So we actually choose the multiple behavior tests to evaluate individual cognitive domain. For example, we use the trial-making test to look at the speed and flexibility. We use the DigiSpan test to testing their working memory. We also look in the use of flanker test to testing their attention, exact attention. We use the face name test to testing their episodic memory. It's important, not only we testing all the cognitive ability, we also look in their emotional control. That is for example, if we develop a memory enhancer, what if this memory enhancer always in fact enhances their negative memory? What if because fear itself is a memory, right? What if we enhance fear memory? What if we enhance memory of failure, which relate to the depression, right? So we have to look in their anxiety. We also look in their general emotion. Finally, actually, Barbara has talked about it, and this is really one of my fans. I'm very interested about it. That is the sleep. In elderly, actually, there's just last 2 years show very strong correlation between the sleep problem and lost cognitive ability. So to us, we also interested to say whether we actually, and our latest understanding is the sleep, the brain structure we control in sleep, had a very similar structure with the cognitive cognition. So the sleep loss, the sleep ability is part of the problem. So that's why we also look at sleep. So again, we get into now this case, the case is just follow the FDA regulation, double-blind, placebo-control, and one is the sugar pill, another one is our compound. And the study was done in Miami. And eventually, we have choose about, it's a clinical trial. The problem is pretty slow. It takes a long time. So phone screen about 1,000 patients. Finally, we got 51 elderly with the MCI, mild cognitive impairment, and randomized into 2 groups. And then we actually compare their cognitive ability. So I don't want to get in, given the time, I won't get into detail. Essentially, this is a trial-making test, and that was developed originally by Army to look in general intelligence. Essentially, there's a part A and a part B. The part B is the one side is alphabetical letters, numbers, and alphabetical letters versus number. They have to connect the A to 1. And B to 2, this whole thing takes, and then you value how fast the people can process this information. So here's our test results. In the placebo-control group, and there's no improvement over 6 weeks to 12, there's no improvement. then we got a significant improvement of the trial-making test time speed. We also use the digit span to look the number of digits they can remember. And during the test, then we also got the significant improvement of digit span test score. And we also use the flanker test to look in their executive attention. In this case, we don't achieve statistically significant results. We just get a trim of direction. Remember, the number of patients we choose are relatively small. And finally, we use the face-link association test to evaluate their episodic memory. And again, here we see a trim of increase, but we don't get a statistical significance. So here is the overall score of improved individual cognitive tests. So in here, we evaluate the multiple cognitive domain. In multiple cognitive domain, and there is some domain we got a statistically significant improvement, and some domain we only got a trend looks like getting better. Now, here's the interesting part. Interesting part, actually, if you look at how FDA or patients, a physician evaluate the people's function, they actually like a CDR, the global dementia rating, ironically, or even what they call RANBAS. They're actually, those scores are composite scores in terms of they quantify multiple cognitive function, like executive function, working memory, and episodic memory, and flexibility. They combine all the score together into a total score. So in this case, if we just actually do a Z-transfer of all the score and generate a composite score, so we'll combine all the cognitive ability together, finally we got a pretty interesting results. The composite score of individual cognitive tests, which give us the fluid cognitive ability, and then here we got a huge improvement. We got a significant improvement at 6 weeks. We got a large improvement, coordinate distance 0.9, and within 12 weeks. So then we got actually nice results show we can improve cognitive ability of patients within actually just 3 months treatment. Now, another thing actually is interesting is I think that she just mentioned about the sundown syndrome. That is the patients, actually Alzheimer patients, are much better in the morning and go down in the evening, which means if you talk about from their cognitive ability, their individual cognitive ability fluctuate within 1 day. Morning is better and evening is worse. So in this case, actually, when the people have a cognitive impairment, those patients we choosing are much earlier. Like they just, in fact, most people just have a memory complaint in this case. And then the question is, then we look in their cognitive test score, and you can see their test score actually fluctuate. So this is the testing score between the two evaluations, like from baseline evaluation to 6 weeks, and a baseline evaluation compared to 12 weeks. So here actually is the results from placebo group. And there is a random fluctuation of cognitive ability. Some people go up, some people go down. But after treatment, in the treatment group, there's only one patient we saw there's going down, and all the patients, their cognitive ability just going up. So in this case, if we compare their cognitive ability between the two tests, the statistical variation of the ability of cognitive ability in the placebo group is dramatic, which means sometimes their cognitive is high, sometimes their cognitive is low, random. Because remember, this is not a real AD. In the real AD patients, the variability will be lower because they're always bad. In this case, it's still the early MCI stage. Some days they are better, some days they're worse. But after our treatment, we significantly reduce their bad day. So they're always in a sort of a good, let's call good day. Another thing is what we call the biomarker. So in this case, remember, our working hypothesis is we want to improve their intracellular mechanism, and is our mechanism of action, right? So in this case, we ask the question, is the improvement? Can we predict their improvement? So this here is the placebo control group. In the placebo control group, there is a random fluctuation of their intracellular mechanism concentration. They are not correlated to the improvement. But in the treatment group, there is a nice correlation between the changing of intracellular mechanism with the changing of their cognitive ability. Okay. So that means we can probably select the patients. The good news is we can select the patients. In this case, 75% of patients actually had a positive response, and only there are about 25%, there are 5 patients did not improve. We think that in this case, we found the non-responder, all of the non-responder are not improve their intracellular mechanism. So before I actually talk about this the statistical significance, from FDA's point of view, they are more looking for the, let's say, called statistical significance, right? Whether we can prove statistically our compound really works. But to me, actually, as a, from medical point of view, it's what's more important actually is the clinical significance. Are you really improve the quality of life, right? You can statistically improve, like say, by 1%. What does that mean? So in this case, how do we quantify the clinical significance of our compound? So in this case, the way we quantify is this. So we give them the standardized, in this case, the trial making test. Each of the spot here is normative, the normalized data. That is on average how each patient perform. So that is the age-dependent decline. So our patients come into their biology age is about 60 years old. So they are right here. They are 60 years old, which means on average their score should be right here. This is supposed to be their score range. But their real score is actually about here, which means their brain age is about 70 years old. They have a 10 years impairment to their cognitive ability. So interestingly, after treatment, for 3 months treatment, their cognitive score actually go back to be exactly what the age is supposed to be. So it's interesting in this case that what they show is in our compound, originally we tried to develop a compound for rejuvenation, but our testing results show we did not rejuvenize them. We just actually removed their impairment. So, we are still doing a more clinical trial, and because this is our data in Alzheimer disease model mice, and in this case is A-beta high APPPS1 model mice, where we can show we can actually prevent the cognitive impairment and a synapse loss in Alzheimer disease model mice and prevent their cognitive impairment. So right now we have an ongoing study in the Stanford University on the Alzheimer. We also, because cognitive impairment is not only the problem of neurodegenerative disease, it's also actually a problem of several psychiatric disorders. For example, schizophrenia also have a cognitive impairment. The ADHD also have a cognitive impairment. So we also have a clinical trial in Harvard and the Northwestern testing ADHD patients and schizophrenia patients. So idea is we want to say whether we develop a generic cognitive enhancer for treating cognitive impairment in several neurological disorders. So my early work was done in my lab in MIT with a bunch of students. And then later on, a lot of animal study was done in the Tsinghua University in China. And I have a lot of clinical collaborators. And the reason I'm here is one of my major collaborators right here in Toronto. Thank you for your attention.